conference will now be recorded.
Hello, good evening, everybody. It's the 20th of October. This is Rick. I'm filling in courtesy of lastminute.com for Len. He may be back, but he was having some technical difficulties, and so I came on and assumed responsibility. We don't have anybody new, and we don't have that many people who have questions. So if you've got any questions that you have been wanting to ask for a long time but didn't want to take time, then tonight could be your night. Quick thanks to our sponsors, who are Johnson & Johnson, Bayer, Novartis, Myriad, at least for now, Telix, Blue Earth, and Foundation Medicine. I think that's everybody. And I think we're good to go. So let's start. Let us start with Michael Wolf, because he didn't have time to ask his question last time. Go ahead, Mr. Wolf.
Thank you. Well, the question arises from when I was on last time, I just had an MRI repeated, which showed a new RADS5 lesion, which was not seen before. I've been monitored for almost 10 years with MRIs and PSMA PET scans, so this is a new lesion. And I had a PSMA a couple of weeks ago at U of M, and that came back actually without evidence of distant metastases. So the question is now, where to go, what to do, if this should be biopsied. All the lesions which are there are a total of 3 lesions they're seeing now, or just a new one, and where I should have that done, and what treatment possibly I should consider.
Okay, well, the last time we spoke, I think the concern was that you had a lesion that was right up against the capsule wall and maybe penetrating.
Yeah,
you did
that's
a PSMA, and that PSMA has not shown anything. You said you were going to have an appointment with Dr. Reichert.
That is correct. I just wanted to get to that.
What was the result of that appointment?
Yeah, he basically said that he would introduce me to his radiation guy, Dr. Dice or Des, and that he will probably do seed implants, permanent seeds. That's kind of the information he gave me. And they will also consult with their biopsy crew, and he said he's basically just the quarterback, and they will kind of discuss it and decide, where I go first, either see Dr. Des first, or the radiation oncologist, or the biopsy people.
And this radiation oncologist that he's recommended is DESS, is that his name?
Yeah, and he's at U of M, and apparently he does everything. He does anything from, regular radiation to SBRT to implants, seed implants.
Okay. So for those of you who might be a little lost here, Michael had IRE, focal IRE, in Germany back in 2015, I think. That is a type of electroporation. It's a focal therapy. Our moderator in the low intermediate group, Stuart Jordan, had a combination of IRE and IMRT. Actually, it was IMRT in a tube. It was I forget what it's called now. I've just lost the name, but it's the one that's done in the MRI tube. And he got that at Memorial Sloan Kettering with Dr. Nagar. So the question is, how do we follow up? I'm going to come back to you in a minute, but Julian, you had a recurrence after your focal therapy. Do you want to share that experience with Michael? You're muted. You'll have to start over again, Julian.
Okay, I'm sorry about that.
That's okay.
Back in 2015, I was diagnosed with prostate cancer, and then I heard about focal therapy from a doctor in Galveston, and I decided to do it. And it went well initially, but slowly the PSA started climbing up again, and this took about 2 years, and then it started leveling at 6. But then you know, my urologist said, well, maybe that's your new normal. But then it creeped up to about almost 9, and I said, no, we got to do something. So that's when I went to Dr. Lani Estasiu, and she said, well, no, we got to be aggressive with this. And we started off with MRI, biopsy, and then got on Lupron, and for about 6 months, and then went off of Lupron, and then got on Nubeca and Orgovyx, and also in that time period also had a high dose radiation brachytherapy boost, and then I had they were going to give me 39 radiations around my prostate, but when I did the radiation boost, it dropped it down to 23. So I had 23 only in the prostate area. But I need to mention too that I also had I forgot what that insert is, between my colon and my prostate, so the radiation wouldn't affect my uh, 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 colon. And that was about almost 5 years now. And I ended my treatment about 4 years ago. So I've been cancer free since then, in remission.
Right, right. Now, what was your original Gleason score?
Well, that's a good story. It was 4+4, and then I had Dr. Epstein review it, and he took it up to 4+5, and that
Okay.
scared the hell out of me.
Right. Now, I think that is quite a big difference from Michael, who was a 3+4 originally,
Right.
but his disease seems to have returned, and of course, what we don't know is what it is now.
Right.
So the reason,
And it's in a different location.
right, but I think the different location is less important than the fact that it's come back, because that can be, if it's in the gland, it's not tied to a particular lesion.
I see.
That's the reason that it's come back.
Okay.
And that was one of the reasons why I said to you originally, before you start talking about treatment options, we need to figure out how aggressive is this disease. And
Right.
Dr. Reichert might have flown right over that. And that was why I thought at the time, last time we spoke, start with Todd Morgan.
Yeah, I tried.
Todd
They didn't want me to they didn't want to make this appointment for me. I tried.
Okay, who is they?
The appointment desk, they said you already have an appointment, Dr. Reichert, and we cannot schedule you with another
Well,
doctor.
that's right. But then we said, well, what you're going to do is if it's negative, you're going to go to Dr. Morgan. But that part of the plan seems to have gone out the window.
Yeah, that's true. So I would have to kind of see if I can get in with him now.
Well, I think so. And I think what you got to do is go back to Dr. Reichert and say, Dr. Reichert, I would ask him this question, Dr. Reichert, would your plan change if it turned out that my cancer was now 4 + 5
I see.
or 5 + 4? And he might say, yes, it is, but it was 3 + 4. And you're going to say, yeah, but we don't know what it is now because that was 10 years ago.
Right.
And then you're going to say, don't you think we should really check it? This is how I would address the problem. And he says, well, yes. And then you'll say, well, before we start talking about radiation oncologists and everything else, even though we know that there's nothing on the PSMA, maybe we need, to be talking to somebody like Dr. Morgan and see what he thinks.
I see.
That's how I would do. Anybody else want to comment on this?
I do want to mention, Rick, that mine never metastasized. It was always in the gland.
That's right. As best as we knew, although it always appeared to be in the gland because we never saw it anywhere else.
Right.
Dr. Evstathiou decided to treat it as if it was more aggressive.
Yes.
Now, she probably did that because you were a 4 + 5 when you were originally diagnosed. And Dr. Reichert is probably planning on brachytherapy, low-dose brachytherapy, because Michael's was 3 + 4. But the way I look at it, if there's disease there right now, we really need to know what that disease is if we can figure it out.
Okay.
I mean, the thing is that once 4 + 5, you're always 4 + 5. Yeah, I mean, I shouldn't say you're always 4 + 5. Once 4 + 5, we have to assume you're 4 + 5 until we can prove otherwise. And in your situation, we never took the prostate out, so we couldn't prove otherwise. But if you're 3 + 4, you could have gone up, could have gone down too.
I see.
But you could have gone up. And this is where, if it were me, for my own peace of mind, I'd want to get confirmation on that. Anyone else want to talk to this? Do we have anyone else on here who's recurrent after focal therapy tonight? No. So I don't know.
Is UFM okay to go for biopsy, or should I go somewhere else for biopsy?
I would stick there. I mean, you've got good care at University of Michigan. You've got access to good people. Reichert's pretty good. I'm sure the reason he sent you to Des was because Des is probably the only person there that does seeds.
That's the only they have, yeah.
That's right. So, but if you don't go with seeds, and you could also go with high-dose brachytherapy, which is another alternative, and that should be reviewed with you. Okay. I think somebody like Todd Morgan will review all those options for you. So could Des. Len, I mean, I'm about to hand the whole reins back over to you, but in a situation like this where we've got recurrence after 10 years of focal therapy, which would make us think that it isn't that aggressive, but we don't know for sure. What would you do? Well, I'll let you off the hook and come back to you because Dr. Alfredo wants to say something. Go ahead, Dr. Alfredo.
Sorry, Rick. First, let me just say I agree with everything you've said, but I am a situation similar in that I was initially treated with the laser at UTMB in Galveston, just like Julian. And a few years went by, I think it was 4. My PSA was rising. And so what I had done this year was IMRT, which is, I'm blocking on the abbreviation, anyway, radiation therapy to the whole prostate. I did not have a prostatectomy. And so that was my story. So it was recurrent after focal. I have no regrets about doing the focal. I think it gave me a few years of lower PSA. But once the PSA started rising, the key deciding factor was I had a PSMA PET scan. It only lit up in the prostate. And so that was good. That was suggestive that I didn't have mets elsewhere. And so I elected to do RT to the pelvis, RT to the prostate, a little bit to the rest of the pelvis. So, and that finished in February. So far, so good. But Rick,
Okay,
I second all the advice that you gave so far.
yeah,
Oh.
so it's a very, very similar situation to what Michael's facing. What was your original Gleason score?
Oh, in 2015 it was 3+3. In 2020 it was 3+4, and in 2024 it was 4+3 in one needle.
And you see, this is why I'm sort of saying to you, Michael, it changes.
Yeah.
And before we choose your treatment mode, let's know
Okay.
how aggressive your disease is.
Understood.
Dr. John.
Yeah, I'd like to second that also because, on the surface of it, this is a pretty low risk situation, an entirely local cancer that's been doing not much for 10 whole years and is only a low intermediate pathology. All this is very low risk stuff. But opposing that, we have a Prostate ID score, which is high, and a PIRADS 5 score, which is high. So how do you call it between being aggressive and being conservative? Well, the biopsy, I think, would be a great way to call it. And if they won't do a biopsy, you could do something like a Decipher score and try to break the tie here between high risk and low risk situations. You might be able to get away with nothing more than seeds or high dose brachy. Who knows? But Rick's idea will tell us whether to be aggressive or to keep it really low key.
And really where I have the idea is it's not about what to do, it's who to see. And I really feel that Todd Morgan is going to be the best doc for you in this situation. One thing we're almost certainly not going to do is surgery. So you'd say to me, well, why am I going to see a urological oncologist right now? Well, because for a disease on your level to guide you, he's probably the best person that's there in the whole of Rogel. He's the guy. And because he's smart, because he gets it, because he's not going to give you more treatment than you need, he's not going to do surgery on you, but he's going to sit there and hold your hand more so than even a Reichert.
I see. Okay.
And you can tell him we said so. We really feel that he'll guide you to the. If he thinks seeds are right for you right now, I'd say fine, go with the seeds. Much more than if Reichert said it, because Reichert doesn't really deal with this stuff.
Right, that's what
I
he's
wouldn't have gotten Reichert. To be honest, I wouldn't have gotten Reichert involved, but you did. So then you had to live with those consequences. I would have started with a Todd Morgan.
Well, I tried, but I just couldn't get in with him.
We're just trying to spare you ADT without leaving you vulnerable to a blow up in your cancer. Is your last PSA still 18?
Yeah, no, it went down from 18 to 15. 15 was the last one, yeah.
Well, even a little more reassurance.
Yeah. Okay, well. I will try to get into Dr. Morgan's and see what I can find out from him.
Wasn't there Dr. Schultz somehow involved in this case?
Yeah. This is a distance issue for me. He wanted me to.
Oh, okay.
He wanted me to see Dr. Cheng at UCLA, and he said Cheng could biopsy it and he could give me temporary seeds, but I haven't kind of pursued that just because of the travel burden. It's just not easy for me to kind of travel that distance.
I see. What are temporary seeds?
High dose brachytherapy.
Oh, that's high dose. Okay. Gotcha.
Talking about high dose, which is what Albert does. And you could probably get high dose. You could just as easy get high dose from somebody. I don't know who does it at Rogel, but somebody's going to do it at Rogel.
I think they don't do it at U of M. That's what Reichert said. I'm not sure if that's true, but.
Oh, okay. Well, then I'm sort of surprised. But if if Dr. Todd thinks that would be the best for you, he's going to tell you. We'll find somewhere that does do it.
Okay.
Maybe they do. Maybe they do it at University of Chicago.
Yeah. I mean, should I? I mean, would it be worthwhile to see Dr. Cheng? I mean, is he a good guy?
He's a great guy, but I think you're fine, and you'll come to a treatment decision. And if it's a treatment path that you want to do or you think makes sense, and they don't do it, we'll find somewhere else for you to do. Would I schlep across the country to do that? No, I wouldn't.
Okay.
You can do it. You can do it a lot closer.
Okay. All right.
So so that's where I go. So let's move on, and Len, take over. And I'm just sending you a note. There was Al Latimer should have been on the list, and he wasn't. So there's another person for you. I think he just dropped off, but he'll be back, I'm sure. But if you can add Al Latimer to the list of the other people that are there. Oh, and we can't hear you, Len. So have you checked your settings? It's probably something to do with that headphone. Have you gone to the settings and selected your headphone? You have. All right. Well, I'll keep going. My guess is, because you were clear as a bell on that headphone the other day. My guess is that it's something to do with that headset. But and I'll move on to the next person. And in the meantime, we'll try and resolve Len. Next person is Jim Cavanaugh.
Yes, thank you. Thank you for the advice in the past to seek out a medical oncologist. I have done that and come up with a Dr. Elan Diamond, who was recommended to me by a second opinion urologist I spoke to at Summit in New Jersey. So I'm planning to contact him tomorrow or the next day to see if I can get an appointment. He's in Clifton, a Dr. Elan Diamond. I don't know if any of you recommend him, but he's highly recommended.
Well, my first question is, does he specialize in genitourinary disease? I think I have heard of him, but I can't say I know it.
Yes, he had a BA from Hopkins, an MD from Weill Cornell, and practiced at Holy Name Medical Center. He was stationed in Clifton. He had very high marks.
Oh, okay. But the question is what he trained in and what type of oncology he trained in, Jim.
Okay.
That's the question. It's not so much where he trained and what he did. It's where his fellowships were and what type of practice he has, and if he considers himself to be genitourinary medical oncologist now, or if he considers himself to be a general oncologist.
Well, the list.
Knowing my guys, somebody's working at looking him up right now. How does he spell Elan? I-L-A-N or E-L-A-N?
E-L-A-N.
E-L-A-N. Diamond. Well, I can't believe nobody's found him yet. MD, New Jersey. So that's what you definitely want to be looking at. He's a genitourinary and urologic oncology who specializes in the treatment. Perfect. And he's with Summit Health. Would he be our choice in the area? Probably not, but it may turn out he's really good. And he is a GU med onc, and we feel that's what you need right now, a GU medical oncologist. So come back to us and tell us how you do with him. You're going to try and get an appointment with him, is that right?
That's correct.
Okay. Well, he has the right credentials, so that's the most important thing right now.
Very good.
Anybody?
Are you still on Orgafix, or no? You stopped it, right?
I stopped it on the 18th, and I've been doing a little bit better, not sleeping as much, not feeling as exhausted, and I've been putting
The
on
18th
some weight.
of which month? The 18th, October 18th. You stopped back in August, right, or something?
It was September 18th, I believe it was.
September 18th. Okay, thank you. And you are sleeping better since then?
I'm sleeping better.
Are you on a machine?
No, on the sleep apnea machine, you mean?
Yeah.
No, I had problems bleeding in the ear. They cleared that and said the ear, nose, throat. That was a separate issue, but I haven't gone back on it. I want an opinion before I go back on it. It was scary.
Is your sleep restful enough? Are you awake during the day that you can delay going back on it?
I haven't. The answer to that is I think I can delay on it.
Okay.
And this is he's in New Jersey with Summit Health. Is that correct?
Right.
That's correct.
And do we have any other New Jersey people in here who might know this gent tonight? We have plenty of New Jersey people, but I don't know if we've got anyone else in here tonight.
Don't know him, but I'm looking at his bio, and aside from Hopkins and Cornell Medical College, before he went to Summit, he was the chief of medical oncology and director of cancer research at Holy Name Medical Center in Teaneck, New Jersey. So I don't know that institution at all, but it might be fine.
No, I don't. I'm not sure. I don't know it either. There is a good hospital in Teaneck, but that's not the one I'm thinking of. Or maybe it's not in Teaneck. Maybe it's right on the cliff there. I can't remember. I can't remember. I'm not even going to go there and try. Now, so unfortunately, Jim, we don't have our New Jersey crew in here. We've got no Peter Monaco, and we've got no, I don't know who else. We've got a bunch of Jersey people, Chuck Snyder and other people. They're all Jersey peeps, but they're not on tonight, so can't really help you. See how you do with it.
I have a little more test information in the sense that Ron Ferrero has a prostate cancer group. They're less extensive than AnCan, but 3 of the people are patients of Diamond, and they were all very, very pleased with him. That's just
okay.
Further information.
That's great.
And the Summit doctor who recommended, when I went to him for a second opinion on things, he said, while he's not working at their location, he says he has high regard. He says one of the top people he knows.
Okay.
So one of the questions I think that you have to get, I'm a little worried about you not being on any medicine at all at this point. You have some significant risk factors. So a question will be, do you replace the Orgovix with something?
That's correct. My current urologist, he was on the premise that after I get my November 3rd PSA review, we'll see where it is. And his thought was possibly going on the Lupron. I have a resistance until I have really good information to suggest that I should be doing something different,
Okay.
to be taking more medicine.
So
And
the way I think we come at it is a little differently, because most of these guys think, well, you've got to start with the LHRH drug, whether it's Lupron or Orgovix. What we've seen people, a lot of the doctors we really like do, is come at this by taking a monotherapy ARSI, like monotherapy darolutamide or monotherapy apalutamide or monotherapy even abiraterone. And one of the reasons I wanted to send you over to Chuck Ryan originally was because I think Chuck would be open to a monotherapy ARSI. And what we need to be talking, if it were me, what I'd be talking to Diamond about, and that'll tell us how creative he is look, I did not do well on an LHRH drug. And there's no reason to think if I didn't do well on Orgovix, I'd do any better on Lupron. To me, that's a pretty dumb suggestion. But what about a monotherapy? What about us trying one of the monotherapy drugs? The least, the least intrusive would probably be darolutamide. Although I had this guy, this so-called expert arguing with me about that, and he hasn't seen in the groups he runs anybody finding darolutamide any better than the other ones. Well, we have definitely seen darolutamide to be a lot better based on anecdotal peer experience. That's the best you can get on these ARSIs because we don't do head-to-head comparisons. But when people like Len and David Muslin and others come back and say, oh, I'm doing much better on this than I did on the other drugs, that's good enough for us, anecdotal or not anecdotal.
Yep.
And so what we'd like to see, because I think that Dr. John is onto something here, which is you probably should be on some sort of medication. Could we get you onto a monotherapy? And who's willing to prescribe that? Short of sending you over across the country to somebody like Matthew Reddick, who took our man who was on 2 drugs and put him onto a single monotherapy darolutamide, and he's now doing great, and he's 85. It's hard to find the right doctors who are willing to do it. But if Diamond thinks openly, maybe we can introduce this idea, and we can say to him, look, call Dr. Shmulewitz or call Dr. Reddick, because he'll know both those names, and ask them if you're concerned about just putting a man onto a single ARSI. This to us is the AnCan way. Don't put somebody back onto a drug that they haven't done well on. Put them onto something different.
Right. It makes sense. If you don't object, I would give you feedback after I get an appointment with Diamond, crossing my fingers that I can get an appointment.
Yeah, let's keep trying for that. Anybody else have anything they'd like to say on this? All right. Well, we're still going to keep going, and I'm not sure. Oh, Len is there. Len, if we can't, can we hear you now or not? No. Call in, Len. Why don't you call in using the phone, and then we'll get your visual, and you can run the meeting on the phone. So we'll look for you coming in right here on the phone. All right. The next man on my list is Eric Curtis, who's been in and out of the meeting a couple of times already. I think he must be having some problems there. Eric, you're up, and tell us what's on your mind today.
Well, thank you very much. First of all, can you hear me? I haven't used
very well.
Okay, fine. So, I understand that in the big picture of things, we get assessed. We're given the best guess on what kind of a treatment works, and then we keep our eyes peeled for how things turn out. And if it works, good. If it doesn't work, then we try something else. It's all pretty straightforward. I'm right now, just a reminder, I'm originally diagnosed with Gleason 4+5 back in March of 2024, and went through SBRT plus IMRT at UCSF. With Dr. Mack, and I've been on duplicate medication since May of 2024, and I can see May is in my sights coming up, because I was told that I needed to be on this for 24 months, and I'm not really excited about the side effects from these drugs. So I have a couple of questions. One, is there any reason why I should not ask my GU-onc to change over to Orgovyx with the hope that the side effects wouldn't be quite so bad? One. Two, getting close to my cutoff date, I'd like it to vacate my system as quickly as possible. I understand Orgovyx actually washes out of my system faster than Lupron that I'm on right now. And three, is there any possibility my duplicate medication is enzalutamide, which I've been on now for some time? Can I get away with just being on enzalutamide? The exhaustion, the hot flashes, all the shit that goes along with side effects is kind of driving me nuts. So I'm looking at this date, May, coming up, thinking about what's going to be the next step and where do I go, or do I really? I was listening to last 2 weeks ago, Thomas McIntyre, somebody who actually had very similar, another gentleman in this group who had similar diagnosis to mine, who was saying, well, maybe I ought to just stay on duplicate therapy and not be thinking about going off. Because the last thing I want to have is recurrence. But the other factor in my case is that I do have a Decipher score of 1.0, and it's so maybe I'm whistling Dixie that I should, and that in fact I really don't have a case of over-treatment, that I should probably be thinking more along the lines of keeping it together. So those are my thoughts and my concerns and my questions at this point, and I'm just kind of throwing that out there for someone who might be in a similar situation to see if they've had to deal with that before.
So we'll ask everybody, because I think that there isn't a person in this room right now, maybe with the exception of Jim Cavanaugh, who hasn't said, is the period of time that I'm on ADT the right period of time? And let me switch that to, in more recent years, is the period of time I am designated for doublet therapy the right period of time? Now, I can tell you that when I was going through this and I was on a singlet because doublet wasn't even used, first of all, abiraterone hadn't even been approved yet. So everybody was talking about how long should you stay on the singlet? 4 months or 28 months, 18 months or 36 months? There were all these variations. And I remember something new coming out. I think it was the 18 versus 36. And my asking my doc, who happens to be the same as your doc, it was Mac Roach, and he said, who knows? You know, we don't know if 18 is the best or 24 is the best or 36 is the best. We just don't know. So I went with what Mac recommended, which was 28 months, and it turned out to be a very good recommendation for me. Did I want to do it? No. Was I miserable? Yes. Was it right? Absolutely, it was right. So when you say, well, how long should I be on? I think that, you can trust that Mac really understands these studies. He's looked at them all and he's taken it into consideration. And he said at the outset, you need to be on doublet for 24 months. Now, we've adjusted the doublet because your body didn't handle the abiraterone that well, and abiraterone does get processed through the liver. Now they put you onto enzalutamide. Could we move you to darolutamide? We probably could. That's a very fair discussion to have with Mac. What about darolutamide monotherapy? Well, if you're really getting crippled, I think it's a discussion you could have with Mac too. I think he'd be open to it. So, and do you need to be on this drug for the rest of your life? I don't think so. I get very worried about doctors who say you got to be on this for the rest of your life. We're not, thank goodness, in your situation looking at a recurrence. This is all part of your initial treatment. Was your initial treatment required to be strong? Yeah, it was, because you were a 4+5 and you had that that level of 1 with your
decipher.
So, Dr. John, what do you think?
Well, I was going to speak, but I think you said everything I was going to say. My history is very much like yours, except we had different primary treatments, but same Gleason scores, same lymph node metastases, same germline results. I did 2.25 years, actually maybe closer to 2 years. I think I would vote for staying on both drugs the full 2 years. I don't see any harm in switching Enza for Daro or switching Lupron for Orgovyx. They'll do the same things and they'll keep you protected until the date in May comes along. So that I'd play it quite safe, just managing side effects, maybe or maybe not with drug shifts until the 2-year mark anyway. After that, a whole different question will come up. We want to get off before 2 years so we don't have side effects, but a lot of us, when the 2-year mark gets here, suddenly we get a little bit gun shy. And we say, oh, wait a minute, it's protecting me all this time. I'm a little afraid to give it up. I said that to my oncologist, and he kind of yelled at me and said, what do you want to have a heart attack or something like that? In other words, he was saying that these drugs have side effects also, besides just what making you feel bad. They have cardiac and bone side effects. So whether to stay on a darolutamide type of a drug come May, well, that's a decision that you guys can bring up at the time. But prepare for some real ambivalence when May comes along, if you're anything like me.
I'm already thinking about it.
Yeah.
Anybody here, has anybody here switched from an LHRH like Eligard or Lupron, an agonist to Orgovyx, and anyone else switched from any of the other ARSIs to darolutamide?
Well, while I still got the floor, I switched from abiraterone to darolutamide, and it was quite smooth. And all my AbbVie side effects went away.
So it was easier for you on the darolutamide than on the abi, correct?
Much easier.
Okay. And I'm Jeff Markey. You did the same thing. You went from daro to abi, correct?
No, you meant from abi to daro. Yeah, and in 2.5 years of abi, I had 1 month undetectable, and the last 23 months I've been undetectable on daro.
Okay.
I also switched from Lupron to Orgovyx, and the first 5 months I didn't even have any hot flashes, but after that I had them until I stopped taking Prilosec and Orgovyx in the morning. I changed Orgovyx to at night, and I get almost no hot flashes now. It was great. The proton pump inhibitor was a real problem, aggravating the hot flashes and the side effects.
Yeah. Well, we do know that. We tell people to be real careful to taking a PPI with Orgovyx. The other person we knew who had a bad response to Orgovyx and was on a PPI didn't play around with the timing, but you do have to be real careful on a PPI. And we were the ones that pointed it out to Bayer, as I recall.
Well, you take the PPI in the morning. You take Prilosec in the morning, PPI, and so I just took in the evening. When I take my Nubequa, I took Orgovyx as well, and boy, the hot flashes have just gone down to maybe 1 or 2 mild ones a day.
That's really great. Helped. That's great.
But Nubequa, it's so much. I mean, the side effects from I had multiple AFib events with abiraterone. It really raised my blood pressure. Now that I'm on Nubequa, my blood pressure is relatively low. Many days it's 100/50 or 60, and it just no side effects. It's just great.
Okay, Eric, do you take a proton pump inhibitor or not? You're muted. You're muted, Eric.
No, no, I do not. The Lupron and the enzalutamide are the only drugs that I take. That's it.
Okay. So let's go to Dr. Russ, and then we'll sort of wrap this up. Go ahead, Dr. Russ.
Yes, I was on Lupron and then went on darolutamide, and my PSA dropped from 5, close to 5 to 2.3, and I'm now on Orgovyx for the last 2 weeks, and I've noted no difference. So very pleased with the results just with the darolutamide.
And you don't take hopefully you don't take a PPI either.
No, I don't.
No, okay, because it does complicate matters. I think that I mean, we have heard, I mean, I had this written argument with this gent that I referred to in my reminder. And when I went to him and said, you know, people, we see guys doing so much better. Well, there's been no direct head to head, and we don't see any difference. And I'm thinking to myself, they don't see any difference. I mean, is he asking the right questions? Because invariably, and I can think about two exceptions, one of which was because the guy was on a PPI, proton pump inhibitor. But invariably, we see people with a much better quality of life on darolutamide. And the studies have reported better quality of life ratings for darolutamide than for the other drugs. But have they been tested head to head? No, because these pharmaceutical companies, they have a peace pact. And they don't want to test one against the other. But if you ask most guys which they prefer, especially when they've been on more than one of them, darolutamide wins hands down. So I do think that if you're struggling with fatigue and side effects, that you can have a reasonable discussion with who was it that moved you from the enzalutamide to the abiraterone? Was it Mac or somebody else?
No, somebody else. I have an oncologist here in Hawaii who I actually see here, and with the numbers went off with the abiraterone when the numbers got really bad, my enzymes were going wonky. Then, you know, he essentially said, applying for Medicare coverage, enzalutamide is far easier than the other inhibitors. And so I said, fine. But he said they all do about the same thing. He did mention that darolutamide and there's one other that they all do roughly the same thing.
Well, they do, but it's very rough because they work in different ways, and the enzalutamide, the darolutamide doesn't cross the brain barrier, and that's why people do better on it. So, you know, you have to go back and advocate for yourself, and you have to say to him, I really want to be on darolutamide. I need you to justify it. If he's not willing to do it, go back to Mac and ask Mac to switch the prescription.
Yeah.
But there is a distinct difference between them, and you have to make the case, or you have to get your doctor to make the case. What are you thinking, Dr. Russ?
Well, I'm thinking that the default is, especially in my case, when I had a PSMA that was positive for small lymph node metastasis in the pelvis, that they wanted to put me on abiraterone. I'm 83, and I just, you know, I had to say no. I don't want it. I mean, I read up on the side effects. Darolutamide seems much safer, and for a lot of different reasons. And just going on the darolutamide, as I said, took my PSA from close to 5 down to 2.23. So anyway, it's just like, it's like the default to go to that drug, which seems to me a lot more toxic, and especially with the need for prednisone.
Mm-hmm. Mm-hmm. Well, they've pulled Eric off because his liver enzymes went out the window, went sky high due to the abiraterone, which Abby can do. But I think that if you're still wrestling with these fatigue issues, that we've got to get you onto the Orgovix. I do think that's a good idea if you can get your insurance to pay for it, and B, get yourself onto darolutamide.
Yeah. Yeah.
So
Okay.
it's not always easy to do that. You try with your local Hawaii-based MO, but if he can't do it, then you have to go talk to Mac and say, Mac, I really want to do it, and I'm sure that
Yeah.
he's going to support that and try and do it. All right. Anything else for Eric?
Thanks, guys.
Okay.
Appreciate it.
Keep coming back. Keep talking to us. All right. Now, yes, Al Latimer's back with us, and Mr. Latimer, you are next up.
Yes, hi. Yes, hi, Rick.
Hi,
I accidentally hit the leave button, but I'm back again.
Okay. It's not so easy to get rid of Al Latimer. I want people should know that.
Yeah, keep trying. So I guess maybe most of you know that I've been I was diagnosed in 1995, so I've been dealing with this shit for a long time. And so now where I am is that I've been through chemo, I've been through the Pluvicto, and my PSA every time I stop with the therapy it starts going up again. And then this past spring in April, I had some other issues, and I didn't do any treatment at all for like 4 months. And then when I started again, my PSA had skyrocketed, and I'm back on Taxotere now, Taxotere plus carboplatin plus abi. So I'm on a triple therapy right now, and it has stopped the PSA from going up. The side effects, mostly fatigue, have well, I'm lying down on the couch right now, but I don't really need to do that. You're going to get the wrong impression. I was just being lazy. So I'll sit up. So my PSA right now is 800 and change compared to you guys. They're 1, 2, 3, 5. But I'm still hanging in there. And like I said, the combination has stopped it from going up. It's actually gone down some since I've been able to get it back again on a regular basis. I have another treatment this Friday, and I'll get a new PSA. We'll see whether it's still stabilized or it's gone down or whatever. But I know that this is not a long-term solution, and I'm looking around for other things to do. Some of you may know I applied for the Alpha Break trial, which was not Pluvicto, but an actinium-based therapy, and I did not fit the profile, and so I did not go on to that trial. So I guess that's generally speaking where I am right now. I've had some other issues that have kind of gotten in the way too. When back in April, when I had my ureter blockage, which caused an infection when I was in the hospital, I also went out of sinus rhythm. I went AFib, and so they were fooling around with my meds with the Mayfib. And when I got out of the hospital, they put me on Eliquis in addition to the other meds. And the Eliquis has been driving me crazy. Every time I touch something, I get another bruise. And when I was, so in late August, early September, we went on a trip, and I was in London, and I suddenly started getting a lot of blood in my urine from the. I still have a stent in my right ureter, and I thought it might have something to do with the Eliquis. And I messaged my doctors back in the U.S. and they said, "Well, let's take you off it and see what happens." Well, I went off it, and the bleeding stopped within a couple of days, as there was no more evidence of blood in my urine, and so that was a relief, because we were going to be away for several weeks, and I didn't want to have to deal with that in London or Europe, wherever we were. And I've been fine since, but my cardiologist wants me back on the Eliquis, and I've been resisting it. So that's just a little sideshow that's been going on, and I'm still not on it. And my arms have cleared up a lot. My arms were just covered with bruises. Just, I touch anything and I was getting a bruise. So anyway, that's just a little aside. So that's kind of where I am. And I need, I'm looking for something else to do, because I know this current regime is certainly not a permanent solution.
So let me just clarify on the current regime. You're on docetaxel, not Jeftana, not cabazitaxel. Is that right?
Docetaxel, yes, that's correct.
Okay, and why? Because you were looking at Jeftana. Jeftana wasn't doing it for you. Is that the reason?
Okay, so I was on Jeftana prior to my other illnesses in April, and it was not. My PSA had started creeping up again. So when I had cleared my other problems, and I started chemo again, talking with Dr. Belusic, I had been on Taxotere before, and when I stopped it, my PSA was still going down. So I was thinking, well, let's try something different, rather than different but the same from the Jeftana, which didn't seem to be working that well. Didn't seem like I was kind of at the end of the road on that. But when I started the Taxotere again, we added carboplatin to it, and abi, and it has kind of arrested the upward trend. It's been down. It's down some from its high, and like I said, I'm going to have another PSA test this Friday.
Okay, so right now you're doing docetaxel, carboplatin, abiraterone, and prednisone. Are you doing an LHRH as well, or you're not doing an LHRH?
Well, you mean to suppress testosterone?
Yes. Are you doing Eligard or?
Well, I'm still on the estrogen patches, but my testosterone is undetectable. So.
Okay, so you're not doing Eligard or Orgovix or Firmagon or any of those?
No.
Okay. So before we talk about what else might be out there, who has something they'd like to respond to with respect to this current treatment regimen for Al? Anybody? And your PSA is up around 800, correct?
That is correct. It's 800 and change. I can look up the exact number if you.
That's okay. That's close enough. That's close enough. Anybody have anything they would like to say before we get into the next stage of this? I guess not. Not even from Dr. John or Dr. Russ or Steve. Steve, thank you, Steve Lodge. What are you thinking? Steve Lodge, we can't hear you. Are you muted? I've just got to find you on my screen here.
Okay, hello.
Yes, hello.
Yes, when you went off Eliquis, did you go on to 81 milligram aspirin or anything else? Yes, I am now on the low dose aspirin, which is certainly better than the Eliquis. But that's a story to be continued. I've since sought out a second opinion. The cardiologist I've been seeing is at Cleveland Clinic, but I've sought talking to Dr. Belusic about it. We decided to get a second opinion from University of Miami, and that's a work in progress at the moment.
Okay.
Go see Mitrani at the University of Miami and let him put something, if not a Zeo patch, maybe an implantable device that monitors your atrial fib, and let's see what your burden of atrial fib is realistically before loading you up with Eliquis. You may not require it. I don't know how many episodes you've had and what your burden is.
I had never had an episode in the 76 years. I had an episode in the hospital when I had this severe infection. And I have not had another episode since, even though I've been off and on. Well, I'm on different meds now to help control it as well, but I have not had another episode.
Go see Raul Mitrani. He's a world-class electrophysiologist at Miami. He's excellent. He'll help you out with that because you sounds like your burden is very low, and
Okay.
I can't see that justifying your being on Eliquis.
Jack, would you please put his name in the chat window for us?
Mitrani, I don't know how to do that. Mitrani.
We got to teach you, man, because everybody else needs it.
All right, if you want,
You've done it before. We know you can do it. Go on, we know you can do it. Everybody's pulling for Dr. Jack to put something in the chat window here. You'll do it. And by the way, you can go back to Dr. Belusic and you can say to him, Dr. Jack thinks I should see Mitrani. That's what I would do. That's what I would do because Dr. Jack carries some weight with Dr. Belusic. What do you think of that, Al?
Sure. But I need to see it in the chat window. I don't know if I can't. Is it in there now?
Not yet. We'll tell you when it's in there.
Okay.
We'll get it in. Jack's working on it. So the only other thing that slightly concerns me, but as Jack points out, your burden's very low. You may not have a major problem, but as we heard from Jeff Markey, abiraterone does have a bit of a reputation when it comes to issues like electrocardio. So, you know, if you've got some electrocardio stuff going on, abiraterone may not be the best drug.
Okay, well that's
Jack's got it. But all right, Jack. I'm giving you applause, and I'm giving you love. There you go. Look, they're both there from me. Anybody else want to join in for Jack? Please do so. Oh, and Dr. Alfredo's giving you some applause, Dr. Jack. So we're doing good here. So there you go.
We thought you couldn't teach an old dog new tricks.
Depends how old the dog is. We may agree on the dog, but we don't all agree how old he is.
Jack's only 18 in dog years or something like that.
Okay, but seriously, Al, I think that's a really good idea. I mean, see Mitrani, and let's let's see, and also talk to talk to either Matrani or talk to the oncocardiologist. There is one there because I know I have looked that up before about, is abi the best for you, or should we be putting you back onto a blocker? But at the same time, you know, your disease and you are so fickle, it may not be, you know, if it ain't broke, don't fix it. And so I can see why we would say, okay, you had a little AFib, but you seem to be fine, and it's coming down. How much has the PSA come down since you started on this regimen?
Less, I don't know, about 100 points, I guess.
Okay, so you know, let's get it down. If it's brought it down over 10%, maybe it'll keep coming down.
Yeah, well, like I said, I'm going to have another PSA this Friday and another treatment, and that'll give me a little better idea of where this is, where I might be heading with this. You know, and then the other side of the coin is that the side effects aren't nothing. The fatigue seems to build over time. I know I recover slower each time.
Yeah.
Back on the Eliquis for a second. I also have this Apple Watch that has an ECG on it, that I can measure my own heart rate, which since this started, I've been doing it all the time, and I've never had one instance of it. Not that it's foolproof, but apparently the watch is fairly accurate.
Okay, so I want Jeff Markey has his hand up, and I'm just going to ask him to hold for a minute. I want to just say to you, what are the treatments? Well, you and I have discussed this. I know that you're not thrilled with Dr. Franco, but he does have access to an alpha. He can get access to an alpha molecule. And an alpha molecule may make a lot of sense for you. Yes, you have to pay for it privately, but you were willing to do that, willing to go over to Germany, and Miami's a lot closer. So I don't know. I mean, I think that the alpha molecule is one definite alternative. Anybody else have any other ideas? Go ahead.
Rick, what about the terbium 161? And
well,
you know,
it's not here. I mean, I think to get him to terbium, we'd have to send him to Melbourne, and whilst we could definitely write.
Switzerland is doing it.
I thought Switzerland's collaborating, but I think the trial is only being run out of Melbourne.
Peter Mack, right?
Yeah, I mean, I know that Switzerland. You're right. The lab the lab in Lucerne, or wherever it is collaborating, but I don't think they're running the trial.
Christina Muller. Yeah, I took notes on that. It was very good, very interesting, and I thought.
Yeah, no, it's good, but I don't. I think it's only it's only Peter Mack. I think. Anybody else have any ideas on other treatments?
Maybe Belusic would know about that.
Yeah, I mean, you know, you talk to Belusic about the terbium. Talk to Belusic what he thinks about you getting an alpha. Jeff Markey.
Yes.
Yeah, I was going to mention I had 4 AFib events on abiraterone, and the third one landed me in the hospital for 4 days. 3 days in a row, I had my pulse was 125 laying down, 175 standing up. I was on Pradaxa the whole time. I never had any problems. Pradaxa is a blood thinner that works really well. They can even reverse it if you have an emergency. You might want to talk to your doctor about that. Both my wife and I take it. I've never seen or heard of bruising. Never had a problem with it. So just something to consider. And 3 days in the hospital, 3 days with that high pulse rate, and I had no no strokes, no problems. It works.
Well, that's good to know. Can you put that name in the chat window also? Because so I know exactly what it is.
I
It's
did.
not something the cardiologist has mentioned to this point.
Yeah, I already put it there.
Okay, great.
It should be above the other one that you saw.
By the way, when I had the event, my heart rate was all over the place, and I was already in the hospital when it happened, so they were all over it. But since then, I have not had any instance of unusual heart rates. I mean, it goes up and down with the amount of exercise I do.
I'm going to have to I want to cut the conversation on the heart because we've still got a couple more people, and
Okay,
I think we've sort of exhausted it. But
that's fine.
Jim Marshall just put in Pradaxa, which was, I think, the drug that Jeff Markey put in. Jeff, there isn't anything for you on that, but if Pradaxa's the same drug, we don't need to put it in again.
Pradaxa, I see it. Thank you.
I did a private message.
Oh, in a private message. You sent it to you in a private message. Excuse me. Okay.
I see it. I have it. Thank you.
Okay. So, yeah, I mean, I think a couple of these. Oh, Dr. John, any ideas for other treatments, Dr. John, before we move on?
Are you a possible candidate for immunotherapy now?
Well, I had Provenge a long time ago. Is there another one out there that?
Yeah, there are these immune checkpoint inhibitors, but they really work very poorly for prostate cancer. But there are a few of us, a minority, who have a MSI high condition or a high
tumor burden.
Tumor burden. If you ever got tested for your MSI or your, you know,
when was the last time you got sequenced, Al? Somatic sequencing.
Good question. Belusic did it. I guess it was about a year ago.
Okay, well, and did you show up on that sequencing as MSI high or a high tumor burden?
No.
Okay.
I did that in preparation for that other clinical trial I was doing with Belusic.
So why don't you talk to Belusic again? It's a year. Maybe do some somatic testing and just to see if anything new shows up.
Yeah, I was going to bring that up to him next time. Also, so good. Thanks for reminding me.
Okay. Thank you, Dr. John, for reminding us. All right, I'm going to keep going. I've got two more gents. We've got enough time for both.
Thank you, Rick.
Pleasure. Because this is a great segue to Frank Jambra, who is now rechallenging with Pluvicto. Frank, how are you doing rechallenging with Pluvicto?
I'm doing really well. I mean, I did have one episode where I had blood in my urine, but that's happened before. Like I peed and like it was a lot of blood came out and like I had like a hemotube. I call it like a hemotobin, or it's like I don't know, something spit out. But I just really I think I was a little dehydrated. So once I hydrated like really well, my urine cleaned up. And another thing, like I was wearing like the pens for a long time for the incontinence, and I don't even need them anymore. Like I haven't had them on in, I don't know, probably, I'm going to say before like after I finished my first rounds of Pluvicto. But I did my 8th round in my 7th round on September 17th, and I was sick for about 5 days, but now I'm 5 weeks out and I'm like back to 100% swimming. I mean, I dethatched my lawn last week. I'm running around with my grandkids. You know, I'm just, I just like, I just keep going. And so that's it. So I'm gonna be doing my 8th treatment. At, I'm getting confused. Yeah, 8th treatment on October 29th. And I'm just, you know, it's just same routine. But for me, the main thing I found out for me is to stay really hydrated.
Mm-hmm.
And you know, and then I feel all right. But I'm eating really well. I'm not losing. I'm not like I lost. I think I was like 255 when I started. Maybe right before they did the first rounds of chemo, and then after my Pluvicto, I went down to like 205. I haven't weighed myself in like 5 weeks, but I'm eating so good, it's unbelievable. So anyway, I just feel great.
So
What do your
here's the
scans look like,
question.
Frank? Yeah.
Are you eating good in terms of a prostate healthy diet, or are you just eating good?
Well, we've kind of slacked. I'll be honest with you. Like I had diet was just like vegetables and chicken and fish. Like I don't eat ground beef anymore. I'll eat turkey burgers, but we've had a run of some stuff here. So I mean, yesterday I had a Jersey Mike sub. It was the first Jersey Mike sub I had in 2 years. But I mean, yesterday was my birthday, so what the hell? I might as well have a Jersey Mike sub. But anyway, no, I mean, the last week my diet is kind of like I've kind of like slacked, but because we haven't had time to like really make meals, so I've been eating a lot of pizza and stuff like that. But I had some wings last week. I mean, I've been bad this week, but before
That's
that, I was like,
okay.
I've been spot on.
Okay. But don't fall off the wagon, okay?
I won't. I do
What do you,
not like fast food anymore. I like I mean I just got used to eating healthy and I like it.
yeah, but you got to have a reward once in a while for
Yes.
infusions. I mean, my God. What does your scan look like now? Have you had a scan?
Yes. So my scans are unbelievably clear. Like they were the scans before Pluvicto were like black all over, like everywhere. My spine, my ribs, my sternum, my skull, everywhere. And the recent, I don't know how I could get you guys to see the scans. Maybe I could send them to Rick, but my scans are like unbelievably like white now.
Wow.
But then when I went back after like I I don't know when we did a recheck when my PSA started to go up. So they did a new scan and there's like some spots of cancer like I mean like on my spine, you know, on my collarbones, basically everywhere in the same places, but it's not like black. So that's why I decided to go with I was blessed to be able to do 6 more rounds of Pluvicto. And then I'm hoping that after that, the next treatment would be one of the trial drugs that they're working on now will be like not a trial drug anymore. It'll be out there. But I did so well on the Pluvicto, like I got my life back. It's just amazing. I mean, it I don't know. It just amazed me. Like you know, I mean, if you've seen what I do every day, and I just take a rest for when I get the Pluvicto, I'm sick for about 4 days, five. I get the Pluvicto on Wednesday, I'm sick, and definitely by that following Wednesday, I'm back out playing music Wednesday night, and
You the
and
man.
then and then I just keep going.
Now,
So
what
yeah,
about that PSA, Frank? Where's that PSA right now?
my PSA right now is 16.40. And
Okay.
before I started Pluvicto, it was 200, and then after Pluvicto, it went down to one. That went down to 0.87, and then it
Yeah.
came up to 0.187, and then just before my last round of Pluvicto was 16.40, and so I'll get tested again right the week before, probably next week, I think. Yeah,
Okay.
because I get it a week before my my next round.
Right. So I
But I
know
can
you got up
tolerate
to
it.
6.5 before you started this lot of Pluvicto, and it probably continued.
Yes.
Yeah, yeah. But you're
Yeah, it
feeling
went up to
good, and
16.
yeah,
But that, I mean, mine was 200. Here, this other guy's 800. Like, so I don't worry. I don't really worry about my PSA. I
right,
mean,
right,
I'm just cruising along. I'm like
right,
living with cancer. That's like thing. So
right,
yeah.
right. Well, I've got you in my sights. I've had another request for somebody to talk about their experience on Pluvicto, and you're like right up there on the top of my list. So I got to find out a little more. The last guy they wanted somebody in the in further south than you, and I put him with Vic, and that was a very successful clip that they made. I haven't seen it yet, but that's for some, I
Right.
don't even know quite what it's for, but we could be coming to you for a Pluvicto testimonial. I just want to tell you.
I mean, that's fine. I tell everybody about it. I mean, and I'm not ashamed, what I mean, but you might want to polish me up a little bit because, I
Okay.
could get a little bit
Okay.
crazy. I'm
Okay.
willing to be polished up.
All
Okay?
right.
That's what I say.
I'll bring my brush so I can give you a quick shine and polish. All right.
Yeah,
So,
yeah, yeah.
Dr. John,
I,
What do you make of the disappearance of your incontinence, Frank?
I don't know. I mean, like in the middle of the night, like if I have to pee, I'll just hold it. And then I
Wow.
and then like and then I know, and then I got to get up, like I'm only getting up. I got up twice last night, but I go all day. Like I don't know what it is. I don't know. I don't know. It's nothing special. Like at a point I was worried like maybe my urine isn't coming out. But I pee.
mm,
It's if I drink a lot of water, I pee and it's fine. I mean, sometimes I can't hold it. I go when I'm walking my dog, he's peeing, I'm peeing. I mean, I'm just being honest. It's like, yeah. But yeah, I can hold it.
Well,
It's kind of weird.
if you figure out what improved it, tell us right away, please.
I have no idea. I know that I mean I was never really ashamed to wear it depends. I mean like my kids I didn't care if they knew, but it was that whole thing about like pissing my pants, like I was like, I pissed my pants when I was a little kid, and I was like I thought I was like reverting back, like backwards, but no, it's. I said to my wife, I'm not wearing them anymore, and I haven't. I mean, I might
good
get
for
a
you.
little wet spot, but yeah, it's good.
Good for you, Mr. Latimer. You've
Yes,
re-challenged a couple of times.
yeah, yes. Hi, Frank. So I've been through Pluvicto. I had 6 treatments, and then I I I had another 4 treatments, and I had to stop because the dry mouth was just getting to be overwhelming. I couldn't. I was. I just well with ballistic. I decided to stop it because I just the effect on the saliva glands was just getting to be too severe. So I was just wondering if you had a problem with that.
So my mouth isn't dry, but my hands and my eyes are drying. It's like my skin is drying out. So like I play music and I play a bass guitar and like my playing was just not the same. And I told the guys when I played my guitar, it feels like I was like holding a 2x4. And then I came home and like greased my hands up, and there was a bass player named James Jamerson. He played for Motown, all the hits. And he always said that the best way for him to play bass was eat some greasy chicken first. And he never cleaned his strings. That's what he said. So like I try to grease my hands up. I mean, I'm constantly putting that Visine to keep my eyes lubricated. And I'm getting like my eyesight's getting messed up too now. Like I'm getting some really bad blurred vision. and I'm pretty sure that's probably a side effect from the Pluvicto, but I mean, it's almost like I'm afraid I'm going blind, but I don't think so. But I'm going to make an appointment for a guy to check my cataracts, because the last time I went to the eye doctor a few months ago, he said I had some small cataracts. So I don't know, but my
Visine's not going to
skin
do
is
it
dry.
for you. Visine's not going to do it, Frank. You got to get special eye drops that have a certain emollient in it. Anova, one of those. Otherwise, it's not. You know, Visine is good if you're
It
smoking
seems like when
marijuana.
I put the Visine in my eyes, it dries it up more, and then it
That's
starts to
right.
burn.
That's the wrong one. That's just going to constrict the blood vessels. You want to get something like, I think, a Nova, or one of the ones that have something in it that keeps the lubrication. Speak to
All
your
right, I'm going to write that down. Thank you.
Yeah.
Okay. Well, listen, let's move on to our last gent. Well, Henry yielded his time back, but we may have a couple of minutes at the end just in case he changed his mind. But I'd like to go, first of all, Frank, whatever you're doing, don't change it, man. You're doing just great. And what we really want to hear is you thumping away on that bass guitar. We got to get you and Jimmy doing something for us together at some point.
Yeah, I've been trying to play bass my whole life, and it's playing an instrument is not easy. Anyway,
Okay.
Thank you very much.
Okay. John G, come on in. You're
everyone.
on my list. Hello.
Hey, everybody. Just quick, update. I had blood work done, 7 months on abiraterone. PSA is undetectable, but I'm worried because my potassium's really low, 3.3, and my lymphocytes were really low, 576. I'm just wondering if that's something I should really be worried about, or am I being alarmist here?
Well, what was the first one that were low?
Potassium.
Potassium. Okay.
What was your
Go
potassium?
ahead.
Sorry?
Can you repeat the number? What was your potassium?
3.3. And the lymphocytes were 576.
And where do you get your primary care? How do you get your primary care? Your regular doctor?
I have a regular primary care doctor. I'm going to see him in like about a week.
Okay, that's good. That'll be fine.
So it's nothing to be too worried about. I mean, it kind of took a dive.
You don't have to go to the emergency room. You just see the doctor and ask him if he wants you to eat more bananas or what.
All right, I have my bananas here, but
yeah. In that case, I'm telling you, eat bananas now until you see him.
Yeah, I went to Dr. Chat and they were telling me, oh, you gotta go to the emergency room right away, blah blah blah. But it just I was just worried. And the lymphocytes, the 576, that's I guess relatively normal for after radiation and all that. Yeah.
It's hard to say without looking at the pattern of what they've been historically, but I don't think you have to go to the emergency room.
Although, that either.
I would eat the bananas.
All right, good to know.
Dr. Jack, what did you want to add there?
I agree that it doesn't sound concerning, especially the white count being 56, 57. That's pretty good.
No, 576 for the lymphocytes.
Yeah.
What was your white blood cells total?
5,700.
I don't even know. Yeah, I don't even know. Yeah.
That's 5,760.
No, 576. Like, you should
White
have
count?
800. No,
Total
lymphocytes.
white count? Oh, lymphocytes.
Lymphocytes. It should be 800, but 576 is a little low.
We've got a few docs on here, and no one is too concerned.
I want to say this, John, to you in your situation, but it's a general thing for everybody. When we're looking at the blood work that we call a complete blood count, that has your white cells, your red cells, your lymphocytes, or whatever, we interpret the whole thing at once. So looking at one line item is really difficult. If we knew some of the other numbers on the page, I think Dr. Jack and I would be more comfortable. So
You got to see the whole picture and trend.
Yeah, because if we know that your red cells are a little up and your white cells are a lot down and your lymphocytes are this, that, and the other, then we have a picture. But telling us one number off of that page is really difficult. That's all I want to say. I'm not faulting you. I'm just saying, good to know.
And that's true for everybody.
Yes, and that's why I wanted to say for everybody in the future, when we're sharing numbers off of our blood work, have the whole page in front of you, not just the one number that was low or high, please.
Great advice. Great advice. Thank you, Dr. Alfredo. See, it was worth attending just for that piece of advice. It's so important because we see you guys going like crazy and getting so nervous about a single number, but we can't tell you about single numbers. You've got to look about it in the overall picture. And so I'm so pleased that Dr. Alfredo said that. It's very, I couldn't say that, but one of the docs can definitely say it. All right. Anything else for, anything else? And because Henry, are you sure, Henry, you don't want to raise your issue?
I'm all set, thanks.
Are you sure? Okay.
Yep.
All right. So, anything else for John Graff, or are we close? Well, I'll take a couple of minutes right now if nobody has anything else.
Excuse me, Rick, and wait, Dan has his hand up. Dan.
Oh, Dan Moore. Go ahead, Dan Moore. Yeah.
You mentioned a prostate healthy diet. And I think I read someplace, I heard someplace in another group that eating chicken has an adverse effect on the cancer production or something.
I mean, I saw something about that recently, but you know, it's very. I'm not going to talk more about it because I have to bring the research, but I kind of dismissed the research when I read it. Did anybody else read about chicken being bad for cancer?
Yeah, I saw that too. I saw that too. I think chicken is maybe worse than tofu, but it's better than beef.
Well, this is Henry. Well, there's a lot of studies in PubMed. Chicken has what they consider as high in choline, and choline is something that's supposedly creates a more aggressive prostate cancer. Chicken and eggs also.
Yeah, but eggs full of eggs, and then you read something else that says eggs are okay, eggs are good. So, you know,
broccoli is very good for you, and there's loads of choline in broccoli. So I would nix the choline hypothesis. Chicken has either is antibiotic free or pesticide free, and maybe that's bad for you. Maybe that's what they're referring to. But the organic chicken, they say, doesn't have that stuff, but whoever knows for sure.
Thank you.
Well, it's hard, Dan. It's a tough one. I will tell you this because Dr. John finally shared that the initial numbers from our survey from last year, and there'll be more coming out about this, but 63% of people who listen to our groups, our prostate groups, or across the board, change their diet, change their nutrition habits. 63%. Now, we don't know how they changed it. We don't know what they did. We suspect they probably started eating healthier, although there could have been a few of them, maybe just a few of them who started eating more Jersey Mikes. I honestly don't know, but it's possible. But they could have been the people that Jim Marshall suggests should be eating tuna Jersey Mike's, because Jersey Mike's has a tuna sub as well. But we don't know. What I've seen over the years is some things we know clearly are not good, and probably those
I'm reading an article about chicken.
heavier. I thought I was talking, but maybe I was wrong. Was I talking?
I heard a pause for a moment.
I thought I was talking. Well, anyway, but I think you have to find a diet that you're comfortable with, where not a lot of red meat, and eggs. I always thought eggs were bad. But now I read, well, maybe eggs aren't so bad. So I don't know. What do you think, Jeff Markey? Are eggs bad or are eggs good?
Well, the article I saw about eggs said that you shouldn't eat more than 5 a week. But as far as chicken goes, eating chicken with fat with the skin on it gives a twofold increased risk of prostate cancer recurrence or progression. That you shouldn't cook chicken at fried chicken is not good for you. Cooking at high temperatures, pan frying, broiling, and grilling is not good. So if you bake it in the oven, that's what my wife does. That's at least that's what the AI says about chicken. That's what the negative aspects of eating chicken.
Okay, well, rather than the AI, I would rather be reading specific people who we can attribute to. And so that's what I'm looking for. Dr. John has put something we can attribute to. Go ahead, Dr. John. That anti-cancer lifestyle website has some very good recipes on it. I'll tell you that. Go ahead, Dr. John.
I like that. I like that website. They come out with little booklets that are easy to read, and I think it's a good source.
Yeah. So I think you sort of take it all with a pinch of salt, but some things we know are probably not smart, like red meat and lots of ice cream. But once in a while, ice cream's fine. So so don't get too wound up. I will just take this last minute just to say, because I don't want to dispose of this, ignore it, because we'll definitely come back. Maybe next week. I do want to talk about my good buddy Mark Valens, who I mentioned passed away last week. It sort of threw me for a personal loop, even though it wasn't unexpected. And I'd like us to remember him. And so maybe we can do that next week. I've got to try and sell moderating to the whole meeting to Len next week, since he didn't quite make it this week, but hopefully he will. And yes, we will definitely talk about Mark. He was a pretty incredible guy. I'm sort of waiting for his obituary. I did manage to find a great photograph of him, which I used on the in memoriam page. But what can I say? There's a very, very good article, which I do plan to reference, from the New York Times. So yes, we'll do a proper job and a respectful job of remembering Mark, because he was important to this group. He was important to Men Speaking Freely. We treasured him. So that will happen. So, and thank you for the few people that have actually written to me. I appreciate it very much, those of you who did. All right. What time is it? 7 o'clock, on the money, on the dot. How about that? Anything else anybody want to talk about right now? Or is it soup yet?
Soup.
Quoted from National Cancer Institute and National Institute of Health. That's where those articles were from.
Okay, very good. Somebody who wanted to say something. Was that you, Dr. Alfredo?
No, no, it was me, Jerry.
Oh, Jerry. Hello, Jerry.
I just wanted to update a little bit on what's been happening.
Ah, yes, but with pleasure. I'm sorry, I did call your name and you didn't answer me when
Yeah,
I
but
went
then I
through
came,
the
I
roll
came
call.
back in now.
Ah, well, okay. So yes, please go ahead and update us, and then we'll call it a night.
Okay, well, what's been happening is I've been waiting for doctor's appointments, and they're finally starting to happen a little bit. So I have some new values. My PSA was 0.24 on 7/1. It's gone down to 0.23. I'm on no protocols yet, but it it went down just a little bit. And I finally have a testosterone number of 512.
Okay.
I've met with Dr. Griccio, who is a medical oncologist here in Rochester. I qualify for Orgovitz. I've also met with a Dr. Byland today. He's the radiation oncologist, and we're going to do a CT staging in about 2 weeks. And by then I'll have met with the radiation oncologist and we'll figure out what to do there. So I'm going to be going on some sort of radiation therapy and or hormone therapy.
So why are they waiting? Why are they waiting to start you on the Orgovix?
They're not necessarily waiting. The radiation oncologist, I have an appointment with him in 2 weeks.
Well, the reason I say this, and I think you might want to go back to Guercio, is because whatever radiation they do, they're going to want to put you on. They're going to want to start the Orgovix usually 4 to 6 weeks ahead of time.
Okay, well, the radiation oncologist wanted me on the Orgovitz 2 to 3 days, not necessarily weeks, before he started the radiation.
Well, our experience has been that it's usually at least 4 weeks, not 4 days.
It's about your increase.
So that might be something to raise with Dr. Guercio. That sounds a little. Now I realize that this is you're going to go onto a antagonist rather than an agonist, but that said, 2 to 3 days doesn't sound right. Anybody want to comment on that? Okay. I would be questioning, if it were me, I'd be questioning why only 2 or 3 days.
Okay. And I can certainly question Griccio and Dr. Griccio before, when he starts the Orgovitz.
I would go back to Dr. Guercio and ask him, when should I be starting the Orgovix? I understand from speaking to other peers that it usually precedes the radiation by, a number of weeks. Phrase it like that. It's not more than 4. Well, I've seen as much as 6 weeks, 4 weeks, 6 weeks, but okay, Dr. Alfredo, come on in.
Well, I was just going to comment. I'm with Rick. I'm a little surprised that he said days. I would have thought he would have said months. And I'll just give you as we all do, the data point of 1. In my case, my MD Anderson doctor said we're going to start you on Lupron, and we're going to check your PSA level, and we won't start radiation until your PSA drops below a certain number. I think it was 0.4 or 0.2. So his view was you're going to be on this drug for as many weeks as necessary to get there. And it ended up being about 2 or 3 months. And then my PSA got to that level. They said, okay, good. Now let's schedule the radiation. So I don't want to generalize from that anecdote that that's the way everybody does it, but it was MD Anderson. He does this all day long. I'm thinking that was the usual pattern.
Okay, and this is Cynthia here. I was just reading over Dr. Byland's clinical notes after the meeting today, and he did not really mention Orgovix. He mentioned Lupron. So I think there's a little confusion there. So we'll clarify that in the chart tomorrow for a better direction.
Okay, well, Lupron takes a little longer to work than the Orgovix does, because Lupron is an agonist and Relugolix is an antagonist. So that can make a difference of a couple of weeks, but I'd still expect it to be, I still expect you, Jerry, to be on for 4 weeks or so before, and certainly, absolutely, I couldn't see him getting Lupron 2 to 3 days beforehand. That would make no sense at all. And frankly, if they were going to give him Lupron, they would need to give him bicalutamide before the Lupron, and that should have been mentioned in there too. Tony Fig, go ahead.
Yeah, this process doesn't sound right to me either. It takes a while for Dr. Byland, the radiation oncologist, to do the mapping. So that's a process that's going to take, maybe 3 or 4 weeks. But I thought you were already on the Orgovix, so I definitely would talk with Dr. Garskill about starting that. But in my case, I waited to start the radiation after I'd been on Firmagon for several months.
Okay. And Jim Cavanaugh?
In my case, both my radiation oncologist and my urologist had recommended, and I did follow that, and that was having the Orgovix started 6 weeks before my 5 days of intense radiation. And they said that there was a possibility statistically that it gives you a 20% boost with the radiation. That's all I know.
Okay, well, maybe we're a little confused here too. I don't know. They were going to stage the CT staging next week after his MRI on Sunday. So we have another appointment with Dr. Grisho on Monday, the medical oncologist.
Okay, so yeah, I mean, go to him. But to me, if you're definitely going to get the radiation and you've been approved for Orgovix, I'd be asking, when am I going to start?
Okay. Okay. Sounds good. Thank you.
Pleasure. All right. I thought I was off the hook, and then Jerry came in. That was my bad, Jerry, because I did say, oh, I'll come back because I couldn't find you. And then I forgot to come back to you. So I'm sorry I didn't ask you at the beginning. All right.
Okay. But thank you,
everybody. And I'll say good night.
Good night.
Good night.
Night.